Good afternoon. I'm David Dunner, and I'm going to be doing the grand rounds this afternoon. Dr. Marino was supposed to introduce me, but he's somewhere. But I also have a plane to catch. Unfortunately, United moved up my flight schedule. So what I'm going to do is start, and I'm going to finish by quarter of at least. So if you have any questions, you can ask 5 minutes worth of questions. Then I have to leave at 10 of to go catch my plane. In terms of my background, I was trained at Washington University in St. Louis, spent a couple years at National Institute of Mental Health, where I was working with the concept of bipolar I and bipolar II disorder, then spent about 8 years at Columbia University in New York with Ron Feevey and investigated rapid cycling, and about 30 years ago moved to the University of Washington, where I was a professor in the Department of Psychiatry and Behavioral Sciences. I'm doing your job. It's okay. I know about me. I established the Center for Anxiety and Depression at the University of Washington, and 3 years ago retired from the University of Washington and opened a private practice on Mercer Island, Washington, which is a suburb of Seattle. So I'm a recovering academic. And the financial disclosures are on this next slide, and you have a handout. And somehow I left out two, AstraZeneca and Neuronetics. I'm on their speakers bureau for both of those. And I want to particularly thank AstraZeneca for supporting my trip down to Tucson today. It got me out of some really bad, nasty weather. We're going to be talking about bipolar depression and a few words about the diagnosis. I think it's important to have some way of differentiating bipolar from major depressive disorders. Bipolar disorder often comes with a loaded family history. It's much more positive than major depression, and often has people with bipolar disorder in it. But because you have a relative who's bipolar doesn't mean that you have a bipolar depression. Early age of onset is another tip-off, but high episode rates, annual episodes, and if you have more than one episode of depression in a year, you're very, very likely to have bipolar disorder. Depression with psychotic features, postpartum onsets, seasonal pattern, you don't see that much of it down here. We have a lot of it in Seattle, which is why you have all those Seattleites coming to you in the wintertime. And things that cause hypomania, people who get put on an antidepressant and become hypomanic or manic are most certainly bipolar, although in DSM-4 you don't diagnose them that way. That's a mistake that we made. And people who have multiple antidepressant failures can be treatment-resistant depression. About a third of patients with treatment-resistant major depression actually have bipolar disorder, and what's happening is they get put on an antidepressant and cycle. Bipolar disorders are fairly prevalent. Bipolar I disorder, being hospitalized or having a severe manic episode at some point in your life, is about 1%. And I think bipolar II is underestimated on this slide. It's probably about 2 to 3%. And bipolar spectrum are these people who have mild highs in depression, and we're becoming very acquainted with this group, and hopefully there'll be some work in DSM-5 to clarify that. It's a highly recurrent disorder, and it's very suicidal. Our data about bipolar II disorder showed that the suicide rate was higher in bipolar II patients than in bipolar I or in unipolar major depressives, and about 15% of patients with bipolar disorder will die by suicide. It's highly comorbid with lots of things. This is a study by Lou Judd. It was a follow-up study of 1,000 patients or so, and what it indicated is that when, I guess it's 146 patients, sorry, that most of the time ill with bipolar disorder is spent in depression, and that if you think about bipolar disorder, we've really conquered, for the most part, acute mania and recurrence of mania. We don't have to rehospitalize patients for manic breakthroughs the way we used to. But it's the depression that's very difficult to treat and where people spend most of their ill time. This is a list of comorbidities associated with bipolar disorder, and I think it's important to note that not only psychiatric comorbidities such as anxiety disorders and axis 2 disorders and substance abuse, but also medical comorbidities, migraines, diabetes, cardiovascular diseases, and indeed, even without treatment, there's an increase in medical comorbidity and a higher death rate in bipolar disorder when compared to the general population. Recurrence in bipolar 1 disorder is about the same as bipolar 2 disorder. It's about 4 episodes in 10 years if these were untreated patients. These data came from a study that we did on bipolar 2 patients, but the rate of recurrence is about the same for bipolar 1 and bipolar 2 patients, which means that you need to think about not only treating this episode of illness, but to stabilize the course of illness and prevent recurrence of the disorder. So you need to talk to the patient about when they get sick. There are some people who get sick at particular times of the year. I call them May patients or October patients, and I always see them more carefully at that time of year. There's a tendency to deny that people have the illness. It's part and parcel of the illness, and you need to talk to them about it. I just went through about 6 months of haggling with a patient of mine about whether he was actually bipolar 1 or not, and finally he agreed that he was bipolar 1. You'd like to get people well and not just better. You'd like to get people on treatments that they can take for the rest of their lives, because this is a lifetime disorder. And frequently, what we do to treat the acute episode is different than what we do for maintenance. If you think about target areas for treatment, there's acute treatment for mania, hypomania, and depression, and maintenance treatment for mania, hypomania, and depression. And we've done very well on the top part of this. We have lots of treatments. And we've done rather poorly on the bottom of this, where patients spend most of their ill time. So let's talk about acute bipolar episodes. Lithium works, and there are several studies that demonstrate that. Of the antidepressants, you probably should avoid tricyclics. Of the monoamine oxidase inhibitors, tranylcypromine or Parnate is the drug that's been studied. The SNRIs may be problematic. There are some studies that indicate higher switch rates with SNRIs, and there are other studies that indicate you don't switch with SNRIs. I said some anti-epileptic drugs because not all of them work. Gabapentin has no effect in bipolar disorder, and the data for oxcarbazepine is really weak. The antipsychotic drugs, a couple of them are FDA approved for bipolar depression. Things that have been studied experimentally include dopamine agonists, which I think can be useful. Pramipexole and omega-3 fatty acids have been reported to work. ECT can work, RTMS can work, and cognitive behavioral psychotherapy and some other therapies have been shown to be effective. People who have bipolar disorder are more likely to fail to respond to the initial treatment, lose efficacy of treatment, and have a manic switch. In fact, a manic switch with an antidepressant is almost certainly diagnostic of a bipolar condition. Okay, so what about olanzapine? Olanzapine fluoxetine was the first treatment that was FDA approved for bipolar depression, but the data on olanzapine alone are also positive. Quetiapine is also FDA approved. This is quetiapine immediate release, but the data on quetiapine XR using the 300 milligram dose is also positive, so that's also approved as monotherapy. I should point out that the quetiapine acute depression studies showed that 300 milligrams and 600 milligrams were equal efficacy using the immediate release drug, and so quetiapine sustained release was just studied at 300 milligrams. Other atypicals, unfortunately, when atypicals are usually developed for schizophrenia, and then as an afterthought, they're sometimes studied in acute mania because pharma thinks that acute mania is bipolar, and so all of them are FDA approved for acute mania, but then they run out of time on their patent or interest in studying their drugs for other forms of the illness like depression or maintenance. So for the most part, these drugs are not studied in bipolar disorder. There's limited data with risperidone. Clozapine is actually the drug of last resort for those of us who see a lot of treatment-resistant bipolar patients, and we all have a patient or two on clozapine, and the data are really quite limited about its efficacy, but I think, again, it's a drug that does seem to have anti-manic, antidepressant, and mood-stabilizing effects. Aripiprazole looked very promising, but 2 placebo-controlled trials looked very promising until the last 2 weeks when the data just collapsed and the drug was equal to placebo at the end of the study. And we have a positive study for ziprasidone. It was open label. Antidepressants, when bupropion first came out, it was thought to be the real key to bipolar depression. It's the one drug that we have that has least sedation, and often the symptoms of depression in bipolar 1 depression especially are oversleeping, overeating. So this drug works well with the target symptoms of bipolar depression. It's not FDA approved for bipolar depression. For some time it was thought to prevent cycling. It doesn't seem to do that. We have an unpublished study that didn't show that it enhanced cycling or prevented it. It is often used in bipolar patients, and what you can see is some switch rate. Let's see, I'm supposed to use this, and there we go. Some switch rate with bupropion in some of the studies. Here the dizipramine switch rate was higher, and here the dizipramine switch rate into mania was lower. SSRIs, again, not a lot of studies, no FDA indication. Often these were studies with bipolar 1 patients who were not on anything to prevent them from switching, and so there was a significant switch rate. We participated in this study, although I'm not an author on it, and it was patients who were bipolar 1 on lithium, randomly assigned, and depressed, randomly assigned to get lithium, placebo, or imipramine, and followed for about 8 weeks. The switch rate on imipramine was 8% and 0 on paroxetine. If the lithium level was low, about 0.8, less than 0.8, there was a drug effect. If the lithium level was high, there was no drug effect, suggesting itself that lithium has some antidepressant effects, which it does. Other SSRIs have been studied, and generally the response rate has been modest and the switch rates have been impressive. So switching to a manic or hypomanic episode or causing frequent cycling is one of the concerns about using antidepressants in bipolar depression. There's also some suggestion that they may not be all that effective. So certainly avoid the tricyclics, and if you are using an antidepressant in a bipolar 1 patient, be sure that you have something on board that will prevent them or reduce their likelihood of switching into a mania. Lithium, all of these studies are pretty old, 1975, 76. Excuse me, but the pooled data showed pretty high significant antidepressant effect in bipolar 1 and 2 patients treated with lithium over placebo. And the other important thing about lithium is its anti-suicide effect, and we'll show you some data about that in a few slides. Lamotrigine. There are 9 studies sponsored by GlaxoSmithKline of lamotrigine in bipolar depression. This is the only positive one, and it didn't use the primary endpoint, which was the Hamilton. It used the Montgomery-Åsberg. So when you use the Montgomery-Åsberg depression rating scale, the MADRS, you got positive results, but it was only one of 9 studies. So there's a real question about how good lamotrigine is for acute bipolar depression. There's better data for maintenance, and we'll get to that. So anti-epileptic drugs, and again, our research into bipolar disorder kind of got a kickstart in the 80s when valproate was studied in bipolar disorder. There'd been a hiatus between lithium studies and everybody thought we had the cure for bipolar disorder, and then Abbott developed valproic acid for seizures and also studied it for bipolar disorder. There are studies showing that valproic acid, divalproex, Depakote, whatever you want to call it, is effective. There's one double-blind, placebo-controlled study that also shows efficacy in bipolar depression. Carbamazepine doesn't really have a lot of antidepressant data. It was really introduced in the United States by Post and Ballinger around 1980 as a mood stabilizer for patients with rapid cycling disorder. It works better in maintenance therapy as a mood stabilizer than for acute bipolar depression, and it also has an FDA approval, at least the sustained release formulation for acute mania. Not a lot of studies of carbamazepine in depression. ECT clearly works. One of the things about ECT is I really recommend that if you're doing ECT on a patient who's bipolar, that you stop the lithium. There are a series of studies showing that lithium treatment during ECT causes a neurotoxicity, and in some instances that can result in a permanent loss of brain cells and cognitive functioning. And I've seen that in a number of patients who just describe themselves as psychiatrically, mentally dulled after ECT. So I really recommend that you stop lithium, and I would do it for a week prior to giving ECT, because it takes about a week for lithium to clear. The other problem with ECT is that if you have the patient off lithium, and probably not on an anticonvulsant, because that will hamper ECT, that you may get a significant switch rate into mania. TMS is the new kid on the block, and there's this nice study of right-sided TMS in positive sham-controlled study to bipolar depression. We've done a couple patients with TMS in Seattle, and we've got a 50% response rate, but our first patient was a bipolar 1 patient on lithium, and he didn't switch into mania. It's one of the things you have to be concerned about. We did left-sided TMS. He did fine. It's not FDA approved for bipolar disorder, but I think it's actually going to be a good treatment for bipolar disorder. So to summarize the data, we don't have a lot of FDA approvals for acute bipolar depression. We have some promising leads, some things we shouldn't use, like tricyclics, and the likelihood of getting more data is not high because these studies are very costly. So maintenance treatment, we need to prevent maintenance treatment. Lithium is the gold standard. I was trained in a lithium clinic in New York at Columbia University. I'm a lithium guy. I think all bipolar patients deserve a trial of lithium. It's better for the classic manic patient rather than the irritable manic patient. It's got well-established data for efficacy and suicide prevention. The dangers of it is that it's sometimes not well tolerated. It doesn't work well in mixed patients, mixed manic patients, and you need to monitor plasma levels. And as patients age, you need to be cognizant of the fact that their lithium tolerability is going to go down, so you need to lower the dose. This was a study that I participated in with Ron Feevey in New York, and it randomized 50 patients who were mostly bipolar 1 to lithium or placebo and followed them for 2 years. The lithium-treated group stayed in the treatment. The placebo-treated group dropped out, mostly because they became manic. One of them ended up in Globe, Arizona. I heard from the doctor there that our patient had left New York, thought he had something to do with cochise, ended up in the desert, dehydrated, manic. They brought him to the hospital where he destroyed the 25-bed west wing of the hospital, and they were wondering what they could give him to keep him from destroying the 25-bed east wing of the hospital. Acute mania is a dangerous condition. On this same study, it looked as if depression was also benefited by lithium treatment, with the episodes per patient year being about a third of what we saw with placebo. Lithium works better in patients who have mania and then depression, and less well than patients who have depression and then mania. Lithium and suicide, I think, is something that the Boston group has really focused on and accumulated a lot of data. When I was starting off in psychiatry, there were lots of suicides in bipolar patients. When I went to New York and started working with Ron Feevey, we rarely had suicides and rarely had suicide attempts. And all of our patients were on lithium treatment. And we wanted to study suicide in our patients, and it turned out we didn't have any to study. And it was puzzling to me, but when Baldessarini and Tondo published their data about lithium preventing suicidal acts and suicide, it became apparent that we were doing pretty well with lithium treatment. So the suicide and suicide attempt rate is decreased with lithium treatment, and when you stop lithium treatment in bipolars, there's an increase 7-fold to 9-fold. This is a study from Group Health in Seattle. It's an observational study. People were not randomly assigned to lithium, divalproex, or carbamazepine. If you look at the analysis of data, 16,000 patient years for suicide attempts and 14,000 for suicide deaths. And so the rate, because you have to correct for the time of exposure, was significantly lower with lithium than and carbamazepine compared to divalproex. Lithium was lower than divalproex or carbamazepine. If we looked at suicide deaths, lithium was lower than divalproate, and not statistically lower, but the observation here is very small. Not many patients were getting carbamazepine. So I think it's safe to say that lithium has an effect that we don't understand the mechanism, but it's a clear effect in reducing suicidal behavior in bipolar depression. This was a failed trial. Abbott did their initial studies in acute mania and then went on a couple years later to do a maintenance trial. Maintenance trials are hard to do. This study was positive for valproate having a positive effect over placebo. This was statistically different. But as you can see, the rest of the trial failed. There was no maintenance effect against mania, either with lithium or divalproex. And I think part of the problem with doing these studies is that there's a reluctance on the part of some investigators to put prototypic bipolar patients into a study where they might get a placebo. When I was at the University of Washington, we didn't participate in placebo-controlled trials of bipolar I patients because of my experience in New York and the worry that one of our patients would get psychotically manic and do some very destructive things. So I think that this study, unfortunately, was not a positive study. It was basically a failed trial, although it did show an antidepressant effect, maintenance effect for depression in these patients. So divalproex works against mania, probably has some effect in depression. If you have mixed states, it's better than lithium. You get some data in comorbid substance abuse, which is positive. You can start at a high dose, although I don't recommend that. I think if you want somebody to stay on a drug forever, you don't start them at a toxic dose and titrate down because of side effects, because they'll come out of the hospital saying, I'm never going to take that drug again. I always start people at low doses and build up slowly. You may get less cognitive dysfunction than lithium. Weight gain, teratogenetic effects, cleft palate, spina bifida, thrombocytopenia, which all of my patients on divalproex have experienced. The issue of polycystic ovary syndrome is such that I would not recommend divalproate as a first-line drug for women of childbearing potential, and other issues. Carbamazepine, this was a study, it was a German study comparing lithium and carbamazepine in patients with bipolar disorders. Carbamazepine worked better in people who had atypical bipolar presentations. Lithium worked better in people who had more classic bipolar presentations. And the suicide and suicide attempt rate was higher on carbamazepine than on lithium. I think I just said that. So strengths, it's a good anti-manic drug, and relatively little weight gain. Weaknesses, I'm still not sure if it has an antidepressant effect. It has a lot of drug interactions and can cause hyponatremia and agran, and very rarely Stevens-Johnson syndrome. Lamotrigine does not work for acute mania, so if you have a bipolar 1 patient, it's not a good manic maintenance drug. Its major effect is in depression, and here the data was better than lithium for the time to the next depressive episode. I particularly like it in patients who have bipolar 2 disorder. It can be used as monotherapy because you're not worried about highs. The highs never get them into trouble. You're worried about preventing depression in those patients. So it's got pretty good effects in depression, and actually few side effects. The major one to worry about is a series of rashes that you can get and the concern about Stevens-Johnson syndrome. It has drug interactions and a slow titration rate to avoid Stevens-Johnson syndrome. Antipsychotics, olanzapine has some maintenance effects against placebo, and it has a maintenance indication by the FDA. Aripiprazole has a maintenance effect against placebo and also has an FDA indication for that. And quetiapine and quetiapine XR have maintenance effects, but I think in this series of studies, quetiapine and quetiapine sustained release were combined with lithium or divalproate versus lithium or divalproate plus placebo. So there were two positive trials with maintenance, and it has an FDA approval as adjunctive treatment. I think it's useful to think of that as more practical than monotherapy. Drug companies seem to like this concept of our drug works in monotherapy, but in truth, most patients with bipolar disorder are not treated with monotherapy. They're treated with combined treatment. So this is okay. You're going to see this slide again toward the end. You need to treat the disorder. You just don't treat the episode. So you don't treat a depression with something that's going to kick patients into a high, because then the patient will get depressed again, and then you're back to where you started. You're wanting to get patients on tolerable medications and do it slowly. Tolerate, get it so the doses are titrated up so patients will tolerate those drugs. You need to reduce cycle frequency, prevent recurrence and relapse, get patients doing better, and decrease suicidality. Need to do things that get people to take their medication, because it's very clear that stopping medication puts you back to the cycle frequency that you were going to have if you hadn't taken medication. Having said that, non-adherence to treatment is pretty high in bipolar disorder, and roughly half the patients will stop their medication. And I think it's an unusual patient with bipolar disorder who has never stopped their medication. Usually people take it for a while, decide that they know better, and stop it. And if they have a recurrence, that's when you can pick up on it and say, look, now you've had a bad recurrence, you stopped your medication, now you need to be maintained on this forever. Education is important. Psychotherapy can help. And try to make your ongoing treatment as simple as you can for patients. Sometimes that's complicated because some of my patients end up on 5 or 6 different medications. But as long as they're stable on that, I think you don't go messing around with it. The psychotherapies that have been studied, CBT is probably the best studied. There's a therapy that was developed in Pittsburgh called interpersonal and social rhythm psychotherapy. It's a takeoff of IPT, interpersonal psychotherapy. And one of the things about bipolar patients is that they often oversleep, so that you want to get their biological rhythms entrained to the same pattern. This is a study from Spain. Nope, this is not from Spain. This is from Canada. And it was CBT versus a control condition, showing that cognitive therapy plus medication was better than just medication. And I think the effect here may be on adherence to treatment. So education, providing patients with an ability to know more about their disorder, so that, and also families to know about their disorder so that you can deal with breakthroughs when they occur. Often families will say, my son, daughter, spouse is becoming manic, and I can tell because. I treated a woman in southwestern Washington. She was pretty far away from Seattle. She was about 80 years old. She had a nice family and a family doctor who took care of her. It was hard for her to get into any medical center. And I mostly treated her on the phone when her son would call up and say, Mom went down to the Cadillac dealer again to buy 2 Cadillacs. And I would say, okay, we need to call the primary care physician and get her treated. And somehow the Cadillac dealer didn't mind her coming in because she was going to buy a bunch of Cadillacs, which got unbought as soon as we figured it out. But it was that kind of behavior that indicated that she was becoming manic. Sometimes it's certain conversations that patients have. Sometimes it's a twinkle in their eye. Family members can often tell that there's going to be a recurrence. Highs cause lows, so you really want to work hard at preventing highs. So this is almost my last slide. I think for patients with mood disorders, you should acquaint them with the National Depressive and Manic Depressive Association, NDMDA, which is now called the Depression Bipolar Support Alliance. Their website is dbsalliance.org. They are a patient advocacy group. These people have bipolar and unipolar mood disorders. They have a website. They answer questions that you can pay dues or not to them. They do advocacy for people who to get insurance parity for coverage of mental illness. And I think that it's one way to provide some education to patients. There are some books. Mood Swing by Phoebe is my favorite book. It's in paperback. He has a newer book out called Bipolar 2. I like Phoebe's books better than Kay Jamison's books. I like Kay Jamison, but I think her books are too focused on Kay and not enough on the illness. And I think Mood Swing is a pretty comprehensive book about bipolar disorder, and I recommend that patients and families read it. And I also recommend that our residents read it because they're going to learn an awful lot about bipolar disorder from this little paperback book. Mood charting, I think, is really important. This is a disorder that people go through periods of recurrence, and you need to make sure that you're on top of it. It's okay if your team loses to the Huskies on a free play in the fourth quarter. You can feel depressed. But, you know, 2 weeks of solid depression, you ought to come in for an evaluation or anything that starts looking like a real episode of illness recurring. I think it's important to get a handle on it and at least make some decisions about how you're going to be treating it. Mood charting can sometimes tell you that there's more cyclicity involved than you think, so that it's interesting that some patients will have particular cyclicity to their disorder. They will get sick at certain times of the year, or they will get sick in certain patterns. Often it's their sleep that's a harbinger of early sign of they're getting ill. And family members need to be aware of this, and you need to get a phone call. I don't see my patients frequently anymore. Most of the 100 or so bipolar patients that I was treating while I was at the U are pretty stable, and the ones I've been following, except for one, I see about once or twice a year. But I know that if they start going into a higher low, they'll call me, or their family members will call me, and we'll arrange an appointment and do something about it. If patients have ongoing substance abuse, you need to get rid of it before you get any effect of your mood disorder. So you may have to work with a dual diagnosis program, or you may have to detoxify the patient, but the best clinical results I've ever had in treating bipolar disorder have been in patients who've had substance abuse and have stopped using. Those patients turn out to be remarkably well. I finished before I thought I was going to, so I left more time for questions. But if you have any questions, you can give me a call. Francisco has my email address if you need to get a hold of me if there are questions that I don't get a chance to answer today. And again, thank you for having me down here this afternoon. It's actually my first grand rounds at the University of Arizona. Yes.
Thank you very much, Mr. Gunnar. I have a question. In the current issue of the American Journal of Psychiatry, there is a whole bunch of articles, we've seen them, on postpartum depression.
And mania.
And mania.
Right.
But the key sentence that got my attention, and I'm glad you're here to answer, because it bothered me. They claim that the majority of postpartum depression is bipolar II depression.
Well, I don't know that I'd agree with that. When we looked at what life experiences patients had when they first became ill, when I was in New York, and we had several hundred bipolar patients to review, postpartum onset was the most frequent single type of onset among women with bipolar disorder. And it was sometimes mania and sometimes depression. But I don't know that I would say that onset is necessarily postpartum or that postpartum onsets are necessarily bipolar II. I think you have to be aware of three different postpartum conditions. The first is baby blues, which 80% of women have. The second is postpartum depression, which is a significant major depressive episode, which I think probably half of that is bipolar and half is not. And then the third is postpartum psychosis, and that's where you get these women killing their kids. And part of that postpartum psychosis could be a postpartum manic episode. So fortunately, postpartum psychosis is very rare. I think it's 0.1% of postpartum episodes. It's uncommon, but often tragic. I don't know. First, having seen a bunch of bipolar II patients, postpartum onset occurs, but it's not that common. And I don't start the other way, looking at postpartum disorders and finding out which are bipolar or not. But I think that if you have somebody who's been well, who develops a postpartum depression, you certainly ought to be concerned about whether this is a postpartum bipolar depression or just a major depression. I think at least half are not bipolar. Francisco.
Thank you for a great talk. You know, it's nice to hear it from the proverbial horse's mouth. Dr. Donner's been around doing all this wonderful job for so many years and publishing a lot of this really rich data as well. So a bit of a complex question about lithium levels. Can you tell us a little bit about what ranges you like to play to and whether or not you play different ranges for women, men, young folks, older folks, pregnancies? Tell us a little bit about range.
Okay, so Alan Gellenberg, who was your former chair, actually had a really nice study that indicated that levels below 0.4 were not very effective for maintenance. So I would get levels higher than that. Our target levels in New York were 0.6 to 0.8 milliequivalents per liter. The lithium kidney problem that came to the fore in the late 1970s mostly came from Europe with the idea that lithium caused progressive renal damage. Their levels in Europe tended to be about 1 or higher. Our levels in New York tended to be 0.6 to 0.8. We rarely saw renal issues with lithium. And so I think that putting all that together, 0.6 to 0.8 may be optimal for most patients as a maintenance treatment. For acute mania, you need to go up higher. For elderly people, you need to go lower. I would try to keep it above 0.4 if you can. You can give all your lithium at bedtime. It actually is helpful to any renal problems you might get if you give it all at bedtime. And get a level about 12 hours later. I don't have much difference with men or women. There are some patients who have ongoing renal problems and you have to monitor your patients carefully. along with creatinine. And I think it's really important, and we forget that lithium has thyroid effects and renal effects, and it's important to get thyroid and renal function tests routinely on your patients. I was asked to consult on a lawsuit, I think from around here several years ago, where the psychiatrist didn't get any renal function tests, and the patient ended up with bad kidneys. And then the question was this a result of lithium treatment, or was this something that could have been prevented had it been picked up earlier? But the fact that he didn't get any creatinines is the problem. You have to be careful in elderly patients, but otherwise I think 0.6 to 0.8 for maintenance is fine. And if your patient isn't doing well, they're still having breakthroughs, then I would add something to that rather than trying to go up with the lithium, because going up with the lithium dose or having a higher lithium level is going to burn out kidneys. Yes?
You mentioned that lithium neurotoxicity can happen if people are lithium while getting ECT. Have there been other studies with other medications having issues when people are getting ECT?
Lithium neurotoxicity and delirium state has been reported with ECT with lithium on board. There are certain medicines that can cause just plain old lithium toxicity. Lithium toxicity is actually too much lithium in the cells. We measure it in the plasma, but it's actually in the nerve cell that we're worried about, and the brain cell, if you would. So with lithium, the blood level is about 0.6 to 0.8. The red cell level is about half that, and the brain level is about half that. During lithium toxicity, if you give a diuretic with lithium, it can increase the lithium within the cell, and then you can get this neurological picture. And if you think about it, the concentration in the cell isn't very high, but it's probably having effect on calcium and magnesium ions to produce tremors and coma and confusion, and and then lithium will stay in the cell because it traps itself in the body, in the brain cell. It doesn't get out very quickly once you get higher lithium levels. So that toxicity is different than the neurotoxicity that you get with ECT. I don't know. There are some drug lithium interactions, mostly with diuretics. Ibuprofen can increase lithium levels. But generally, these are on the more mild and acute side rather than lithium neurotoxicity and delirium, which is very acute and striking with ECT. Other questions? Thank you for having me. It's been a pleasure to come down in the sun.